If Ozempic gives excellent glycemic control, is taken once weekly, reduces appetite, and promotes weight loss, then why does its use still raise questions? And why is it not considered completely safe? This question arises because clinical benefit does not automatically mean zero risk. Welcome everyone. Today we'll discuss one of the most talked about drugs of recent times, that is Ozempic. Originally developed for type 2 diabetes, it gained worldwide attention as patients began losing significant weight while on therapy. And because of this unexpected effect, its use rapidly expanded beyond its original indication. As its popularity grew, important questions followed. Is Ozempic truly safe? And why have thousands of patients filed lawsuits while taking it? Do these concerns reflect real scientific risks, or are they largely driven by misuse and off-label use? In this lecture, we'll break Ozempic down step by step: what it is, how it works, how it leads to weight loss, its approved uses and dosing, and the benefits and safety concerns that make this drug both promising and controversial. Ozempic is a prescription injectable medicine whose active ingredient is semaglutide. It belongs to a class of drugs called glucagon-like peptide 1 or GLP-1 receptor agonists. Ozempic is designed to mimic the action of the body's natural GLP-1 hormone, which is released from the intestine after a meal. In early 60s, scientists made an interesting observation. They gave glucose to two subjects. One received glucose by the oral route, and the other received glucose intravenously. Despite both having the same blood glucose levels, the person who took glucose orally released much more insulin than the person who received it intravenously. This observation made it clear that glucose itself was not the only signal to secrete insulin from pancreas. Something from the gut was being released after oral intake, which was telling the pancreas to secrete additional insulin. This phenomenon was later named the Incretin effect. Incre means increase, tin means insulin. So Incretin means gut hormones that increase insulin secretion after eating. In the early 80s, researchers, while studying the pro-glucagon gene, found that pro-glucagon gene in the pancreas produces glucagon. But this same gene in the intestine produces a different hormone. And they named this hormone, which is produced by intestine, a glucagon-like peptide 1 or GLP-1. And they found that this is the hormone released from the intestine when we take glucose orally. It then travels to the pancreas and stimulates the release of insulin. And this discovery explained why oral glucose produces a stronger insulin response than intravenous glucose, even at the same blood glucose levels. Once GLP-1 was discovered, scientists immediately saw its potential for the management of type 2 diabetes. A gut-derived hormone that could enhance insulin release after meals seemed like an ideal therapeutic target. Researchers were excited. However, they quickly ran into a major limitation. Natural GLP-1 is extremely short-lived. It is rapidly broken down within 1 to 2 minutes by an enzyme called dipeptidyl peptidase 4. As a result, although GLP-1 worked beautifully in theory, it failed to work effectively in real patients, simply because it did not remain in the circulation long enough to produce a sustained clinical effect. The breakthrough came in the 1990s from an unexpected source: the Gila monster, a desert lizard. They discovered a GLP-1-like hormone in its saliva called Exendin 4. Exendin 4 was special because it was resistant to degradation by DPP4, making it long-acting and biologically powerful. This discovery led to the development of the first GLP-1 receptor agonist drug, exenatide, which received FDA approval in the early 2000s. and marked the birth of this drug class. Later, scientists developed human-like GLP-1 analogs with longer half-lives, allowing once-weekly dosing, stronger appetite suppression, and additional cardiovascular benefits. Ozempic or semaglutide belongs to this class. Through specific structural modifications, it is made resistant to DPP-4 degradation. Now, how GLP-1 agonists work in the body? GLP-1 receptor agonists like Ozempic increase insulin secretion by activating the GLP-1 receptor on the pancreatic beta cells. GLP-1 agonists bind to the GLP-1 receptor on pancreatic beta cells, which is a G protein-coupled receptor. This receptor activation stimulates the adenylate cyclase, leading to increase in intracellular CAMP. The rise in CAMP activates protein kinase A, which phosphorylates voltage-gated calcium channel, leading to increased calcium entry into the beta cell. This increase in intracellular calcium triggers the exocytosis of insulin-containing granules, leading to insulin release. What makes this mechanism clinically important is that GLP-1 agonists don't force insulin release when the glucose is low. If blood sugar is normal or low, the beta cell machinery becomes relatively inactive, so insulin secretion doesn't increase. This is why drugs like Ozempic have a low risk of hypoglycemia when used alone. During fasting or starvation, the first physiological change is a gradual fall in blood glucose because there is no incoming glucose from food. Pancreatic beta cells are highly sensitive to glucose levels, so when blood glucose falls, results in decrease in insulin secretion. Therefore, fasting is essentially a low insulin state. Importantly, insulin does not act only on muscle and fat. It also acts locally within the pancreas. Under fed conditions, insulin release from beta cells continuously suppresses neighboring alpha cells, acting like a brake on glucagon secretion. During fasting, when insulin levels fall, this inhibitory brake is removed, allowing alpha cells to become active even before glucose levels drop very low. Thus, low insulin itself promotes glucagon release. At the same time, low glucose directly stimulates alpha cells by altering intracellular ATP, changing ion channel activity, causing membrane depolarization, opening voltage-gated calcium channels, and increasing intracellular calcium, which triggers glucagon secretion. Autonomic inputs during fasting further enhance this response. As a result, glucagon levels rise while insulin remains low. Glucagon then acts mainly on the liver to promote glycogen breakdown, stimulate gluconeogenesis. These actions help to maintain blood glucose and provide alternative fuels for the brain and other tissues during fasting. Ozempic not only increases insulin secretion but also actively suppresses glucagon release. It does this through a direct effect on pancreatic alpha cells. Although GLP-1 receptors are most abundant on beta cells, alpha cells also express these receptors at a lower density. When Ozempic activates GLP-1 receptors on alpha cells, it alters intracellular signaling, particularly the CAMP pathway. Importantly, the effect of CAMP in alpha cells is different from that in beta cells. In alpha cells, GLP-1 receptor activation ultimately reduces electrical activity of the cell, making the membrane less excitable. As a result, voltage-gated calcium channels open less frequently. Intracellular calcium levels fall, and since calcium is essential for hormone exocytosis, glucagon secretion is suppressed. In addition to this direct action, Ozempic also inhibits glucagon indirectly by increasing insulin and somatostatin release within the pancreas, both of which further suppress alpha cell activity. The clinical significance of this is especially important in type 2 diabetes, where glucagon secretion is inappropriately elevated even after meals, leading to excessive hepatic glucose production and fasting hyperglycemia. By inhibiting glucagon, Ozempic reduces hepatic glucose output, which lowers both fasting and postprandial glucose levels. Crucially, this glucagon suppression is glucose dependent, so the protective role of glucagon during severe hypoglycemia or prolonged fasting is largely preserved. This explains why GLP-1 receptor agonists like Ozempic improve glycemic control with a relatively low risk of hypoglycemia. Another important mechanism by which Ozempic works is by slowing gastric emptying. GLP-1 receptor agonists like Ozempic act on GLP-1 receptors in the brainstem and along vagal nerve pathways that control gastric motility. This results in reduced antral contractions, which is the squeezing movements of the lower part of the stomach that push food forward, increased pyloric sphincter tone, and overall slower movement of food from the stomach into the small intestine. Because nutrients, especially glucose, enter the intestine more gradually, postprandial hyperglycemia is reduced without forcing an excessive insulin response. When gastric emptying is delayed, food stays in the stomach for a longer time, keeping the stomach stretched, a state known as gastric distension. Stretch receptors in the gastric wall continue to sense this distension and send signals through the vagus nerve to the brain, particularly to satiety centers in the hypothalamus. As long as these signals persist, the feeling of fullness is prolonged. As a result, patients feel satisfied for longer after meals, have less urge to eat again soon, and portion sizes naturally decrease. At the same time, GLP-1 also acts directly on the brain to suppress appetite by reducing hunger signals and enhancing central satiety pathways. Clinically, this slowing of gastric emptying has several important benefits. It improves postprandial glucose control, reduces overall insulin demand, and strongly supports weight loss. However, because gastric motility is slowed, some patients experience gastrointestinal side effects such as nausea and bloating, especially early in therapy. These effects are usually most pronounced at the start of treatment and tend to lessen over time as the body gradually adapts. Now the indication and usage of Ozempic. Ozempic is indicated for use in adults with type 2 diabetes mellitus. It is prescribed as an adjunct to diet and exercise, meaning it is used along with lifestyle modification, not as a replacement for it. The primary purpose of Ozempic is to improve glycemic control. Ozempic is not recommended as first-line therapy in patients who can be managed with diet and exercise alone. It is not indicated for type 1 diabetes mellitus because type 1 diabetes is an absolute insulin deficient state. Ozempic is also not used for the treatment of diabetic ketoacidosis, where insulin is mandatory. Additionally, Ozempic has not been studied in patients with a history of pancreatitis, so another anti-diabetic agent should be considered in such patients. And now dosage. Ozempic is started slowly and step by step to allow the body, especially the stomach and intestines, to adjust and to reduce the side effects like nausea. Treatment always begins with 0.25 milligrams injected once weekly for the first 4 weeks. This starting dose is not meant to control blood sugar. Its main purpose is to help the patient tolerate the medicine. After completing these 4 weeks, the dose is increased to 0.5 milligrams once weekly, which is the first effective maintenance dose for glycemic control. If after staying on 0.5 milligrams for at least another 4 weeks, blood sugar control is still not adequate, the dose can be further increased to 1 milligram once weekly, which is the maximum recommended dose. Ozempic is given once a week on the same day at any time of day with or without meals, and it is injected subcutaneously in the abdomen, thigh, or upper arm. If a patient misses a dose, it can be taken within 5 days. Beyond that, the missed dose should be skipped and the next dose taken on the regular scheduled day. This gradual dose escalation is needed to improve tolerability while achieving effective glucose control. If Ozempic gives excellent glycemic control, is taken once weekly, reduces appetite, and promotes weight loss, then why does its use still raise questions? And why is it not considered completely safe? This question arises because clinical benefit does not automatically mean zero risk. The most significant concern is the risk of thyroid C-cell tumors, which were seen in rats and mice with long-term semaglutide exposure. Although the relevance to humans is unknown, this uncertainty is serious enough that Ozempic is strictly contraindicated in patients with a personal or family history of medullary thyroid carcinoma or MEN type 2. In addition, cases of acute pancreatitis have been reported in patients taking Ozempic. If a patient develops persistent severe abdominal pain, the drug must be stopped immediately and never restarted if pancreatitis is confirmed. Because of this risk, Ozempic is not recommended in patients with a previous history of pancreatitis. Clinical trials have also shown a higher rate of diabetic retinopathy complications, particularly in patients with pre-existing eye disease, which necessitates close ophthalmic monitoring. Gastrointestinal adverse effects such as nausea, vomiting, diarrhea, abdominal pain, and constipation are very common, especially during dose escalation, and are severe enough in some patients to lead to discontinuation, which is why slow titration is essential. Severe vomiting or diarrhea can further result in dehydration and acute kidney injury, even in patients without previous kidney disease. While Ozempic alone has a low risk of hypoglycemia, this risk increases significantly when combined with insulin or sulfonylureas, often requiring dose adjustments. Finally, although Ozempic improves glycemic control and weight, the prescribing information clearly states that conclusive evidence for overall macrovascular risk reduction is still lacking. In summary, Ozempic is an effective, convenient, and powerful drug, but concerns about thyroid tumors, pancreatitis, retinopathy, kidney injury, hypoglycemia with combination therapy, and gastrointestinal intolerance mean it must be used selectively, thoughtfully, and under careful monitoring, not casually.